Another course on workforce planning. This is one of the course X's, which is the extra bits, session 3. This is on workforce and process redesign. It's quite a nice light section, just talking about how workforce and process redesign can be done together. It should augment session B3, I think it is, which is the future state planning section. It should make that whole section a little bit shorter, and this is a bit of extra work you can have a look at around process and workforce redesign. Just to introduce myself, my name's Colin Lurie. I work for Carados Limited. We're a management training and development company. We focus on skills such as workforce planning, and it says there as well cost control and other skills, but in reality workforce planning is a lot of what we do, and it runs through all of that stuff. We do that by providing free tools and techniques, such as this one, which is a wrapped redesign, and we work with Lancashire and South Cumbria, NHS Foundation Trust and Health Education England to provide the free wrapped tool, which is available online and is managed by Fiona and Amina in that picture. I am the WRAP director. We are an NHS-based training and development service which works alongside Carados, and we use an interesting approach to development. We focus not only on providing free tools and techniques such as this course, such as the WRAP tool, such as loads of other courses, but we ask that people bring themselves, so they bring capacity and capability to programs, and we work through a project which is important to the organisation or the system to help them develop, to give them a reason to learn, a chance to practice, something to prove success, but critically something that's important for the organisation or the system, so that they are given the time and space to do this and not dragged off onto other things, because most people do not have the capacity at the moment to be able to learn and deliver workforce redesign in what is a very difficult environment. This module is about process and role redesign. We're going to consider process mapping, what other information we might need. We're going to think about downtime, which is an important thing to think about, and we're going to think about role redesign, which we did cover briefly before, but I just want to put a bit more detail on it. It's one of 5 extra courses: data, facilitating a workshop, process mapping, the 7 R's to workforce planning, and wrapped modelling. Wrapped modelling, which is delivered by Fiona and Amina, and it's part of, in most cases, sort of redesigning workshop, this one. How to redesign workforce, which is one of the workforce planning approaches that we have. But we're also going to talk, we'll also have courses on developing a workforce plan, a workforce hub, and frontline workforce planning. So this is how it fits within our overall galaxy of workforce planning stars that we have. The wrapped process we follow is this one. I've seen it a number of times. 5 circles delivered in all sorts of different orders as required, but generally starting with scoping and finishing with implementation. This one, as I say, fits within the developing the future state, but it's also got elements of understanding the current state in it, because it involves process mapping. This is X3, it fits there, as I say, largely fits under developing the future state, and is worthy of a topic in its own right, I think, today. So let's look at it. Let us look at a simple process, all right? Now, you can do this exercise if you like. I'm sure you won't, but you can do it if you like. If you can think about if a referral is received and reviewed by someone, that referral, if it's urgent, is then reviewed to see if it's simple or not. And if it is simple, then a GP clinic's held, admin is handled, and the process ends. But if it's not simple, if it's complex, then it's sent to a tertiary provider. If it's non-urgent, going back to that part of the tree, then a nurse clinic is held, admin is handled, and the process ends. Okay. So, I don't know if you've done process mapping before. There are 2 things you could do at this stage. You could draw out what this looks like to you in a process map, however you like, and you can consider what other information you might need. All right. So take some time to do that. So I could stop. You could stop here. You could pause and do that. All right. But as you're not going to do that, let's move on to the answers to that and think about where we might go with it. So a simple process would look like this, based on that information that we had. All right. And there's a few things to think about. A process should have a start, all right, and an end, and you should mark those with the word start and the words end. All right. It's an advanced course. This. All right. Cool. Secondly, you should have an input. all right? And thirdly, you should have an output, all right? But we didn't get an output in terms of that discussion. But point is, if you haven't got an output, then most of the steps beforehand were pretty useless because you weren't doing anything. It just fizzled out, yeah? So you should have an output. In this particular case, it'll be something to do with the administration, and the patient will move on somewhere else. But we don't know that from what we were given. Blue boxes, or a block's a square, should be a process. Okay, that's a process we can attach a time to later on, or stuff we can attach time to. So receiving and reviewing the referral, you could have that receive referral and review referral as two separate boxes. I've got it as one at this point because, hey. Then you've got these here, these diamonds, which for me are decision points, all right? And that is a point at which something might happen, all right? So in this case, receive and review referral. If it's non-urgent, it goes one way. If it's urgent, non-urgent, it goes one way. If it's urgent, it goes the other. The way that decision points work is that the positive route should flow down. So that if it's yes, is it non-urgent? Yes, it is. It should flow down the screen, and only where it's complicated should it go right. Okay. Now, there's loads of other bits you can add into a process map, all right? Loads. Delays and processes and equipment use, all that sort of stuff can be put in. This is a simple process. It's pretty much all you need from a process mapping point of view in order to do workforce redesign. But if you know a better way of doing it and you're happy with a different way of doing it, knock yourself out, all right? This is for people who don't really have a way to do things. The thing is, we're missing lots of bits of information there. I mean, straight away from that, I can see, well, where's my output for a start? I also don't know how often a non-urgent one is, and how often a simple one is. So I haven't really got much of a process map entirely. I don't know all sorts of other things. And you've probably thought about what other bits of information might we need. So there's all sorts of information we might need. Who does each step? That's pretty important from a workforce point of view. All right, we need to know who does each step. Otherwise, it's very difficult. Also, from a workforce redesign point of view, we need to know what skills are needed for each step. If we don't know the skills that are needed, and it could be skills, behaviours, attitudes, basically what human characteristics are needed for each step, then it'll be difficult for us to do workforce redesign later on. All right. We need to know the scale. How many of those are we doing? Right. That refer to tertiary bit might be 100% of people. Yeah. In which case it's important. It might be 0.0001% of people. In which case, if referring to tertiary takes 1,000 hours and we can halve the time, the level of impact we're going to have will depend on the scale. As I said, we need to know what the chance of each decision point is. And we also need to know where the input comes from. I always want to know where's the input coming from, because I think that's important. Because if receiving and reviewing the referral is a really time-consuming process, then we might need to go back to the input and say, oi, what is going on here? Yeah, because it might be that it's all a bit inappropriate. Yeah, and we need to apply some controls over what's coming in through the door. So we need to know where the input comes from. As I said, pretty blooming obviously, we need to know what are the outputs and where do they go, who do they go to, because again, we need to know what do they use them for. If we're producing a 10-page admin output for people and it's going straight in the bin, then that's a bit of a problem. In one case, I looked at this and went to a GP surgery to say, what do you use the letter for? And they said, oh yeah, very important, the letter. What we do with the letter though is that we take the letter and we scan it in. And you go, hang on a minute, back in the office we're printing it out. But you get it and somebody scans it in before you see it, pretty obviously we can then email it. So you need to know where the outputs are going, what the outputs are, and it allows you to ask some questions later on about what they actually use them for. Don't make assumptions. And then we need to know, quite critically, how long does each step take. That helps with the scale, because scale is about how long it takes and how often it's done. But it is very important when it comes to defining how many people we need in the end, and we can use this as part of our drivers discussion in the model. That is the minimum that you need around that process. Now, there are other things that you can collect around it. You can collect things like what makes that process important for the staff? How do the staff feel about doing it? What's the level of contentment with doing it? Do the staff love it? Do they hate it? What's the story about that bit? What really happens to that in terms of the actual story to the patient? How does it fit within a core narrative of that patient and the core narrative of that staff's role? So we can collect that for some of the more narrative and more sort of arty type things that we might do later on when it comes to workforce redesign. We can collect what equipment is needed. We can collect where is it done. We can collect what digital system do we use for it. There's a whole host of other stuff we can collect for this stuff. I've just given you pretty much what I think are the minimums there, but there's a whole ton of stuff that we can collect if we want to. What happens if that process is done badly? What's the impact? What happens if that process is done well? What issues do we have with that step? What issues do we have with the input to that step? What issues do we have getting the outputs ready for that step? What's strong about that step? All these different things you could collect if you wanted to. There's a ton of things you could collect. And if you've got any more, please write in answers on a postcode to Carados Limited. So here's a few things that we might have then added to that to make that work. So we now know that 50% of non-urgents go to the nurse clinic, and then 50% are urgent and go to the review referral. Yeah, we know that 99% are simple, and that 1% is referred to tertiary. So we can therefore work out that 0.5% following that route will end up going to tertiary. Okay, we know how long certain things take. I've not filled it in. We've got an output now. There's a treated patient, and there's an admin on PAS, and there's a filed sheet. So we know that then heads off onto PAS. We don't know who else uses it, but that's what we know at the moment. Okay, so we've got quite a lot there that we can add to that process redesign. Okay, now I'm going to talk about downtime. I talk about this in the modeling thing a little bit, but I want to talk about it here because I knew I talked about it somewhere. When you are working out how long things take and creating a time, so how often it's done and how long things take, you need to take into account this isn't everything they're doing. All right, this is a process they are following, but it's part of their job. First and foremost, they may have lots of other tasks. All right, so if somebody tells you that 10 nurses and 5 administrators are doing this process, you don't know if there are other things they're doing. So you need to make sure is this all they're doing? Are they doing other things? But even if there aren't any other tasks that they're doing, and which there will be, there's going to be some annual stuff. Yeah. Now, quite often you find clinicians have a 44-week year, and that's because they have leave, sickness, training conferences, and they have maternity leave or whatever else might be added to that. Maternity leave often just provided as a percentage, which I think is wrong. You're either on maternity leave or you're not, and it's not your fault whether you are or you aren't. Well, define the word fault. But anyway, you've at the end of the day, I think that should be taken out of this. But quite often it is used as a part of the percentage. But even if you're counting those sort of on costs or whatever you might want to call them, that 23% that can be applied or the 44 weeks, there's also lots of other things people do. And this is a simple process that you might have timed great. The thing is sometimes they do the process wrong and have to redo it. Yeah, they make a mistake. They have to print a form out. Sometimes the forms aren't ready for them to use and they have to walk and go and get them. Yeah, they have to move between tasks. Just because it takes minutes to review a referral. Actually, I think we've learned how long it takes. It takes 10 minutes to review a referral. Doesn't mean to say that every referral will take that long. There might be. We've done lots of those, but then we're moving to do something else. Then what do we need to do? So moving between tasks and stuff happens. I remember when I was timing work in a post office once. A lady collapsed in the queue. People came out of the post office to help her. That doesn't appear on any process map anywhere, but these tasks can happen quite a lot with fire alarms, breaks, random things that happen, etc. So don't forget, these do not represent the totality of everyone's tasks. Right, okay. Important to know this stuff. Cool, okay. So let's think about role redesign and how that can affect the process. So we've learned this in the main course, is that there are 5 potential mechanisms for job analysis. So there's functional job analysis, task analysis, job element method, narrative task, and critical incident. If you want to use one of those approaches and you've been given a way of doing it, then knock yourself out. Okay, go for it. The way I do it is to use the core elements of those. All right. So what I do is I analyze, and this is what they all do really, is they all analyze the tasks that are being done. All right. So they break it down. Yeah. In terms of that's what we've just done. Yeah. What skills, behaviors, blah, 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 blah. I added to it. We analyze that. We rate how important they are. Okay, so why are they important? Okay, and we understand what skills are needed. Okay, so we've considered most of that in terms of what we've already done, but that's pretty much the approach that all of these take. When you say rate how important they are, for me, it's not so much I do that, but I analyze the tasks and I work out which ones are difficult, which ones are easy, which ones need to be done by different staff, etc. But you need to know what skills are needed. Do we need to be qualified or unqualified in order to do it? Yeah, there's no good saying, oh yes, I could get an administrator to do that when you've got to be qualified in order to do it to meet certain requirements. We need to know who's doing it now and why it is that they're doing it now. Is it history? Is it because we've tried it before and they had to do it? Is it because they're good at it? Is it because they need to do it? We need to know what competencies are needed, what behaviours and attitudes are needed, and are there any legal requirements with regards to the staff that we need to pay into account there. So workforce role redesign is about understanding each of those tasks and breaking it down in that way, and then adding to that task with bits of information. Now, the basic data you need is a description, the number of times it happens, the time each one takes, who does it, and what skills are needed. We talked about that, yeah? But we also talked about what extra data we might need, yeah? So we talked about what's excellent, yeah? We've talked about what data and what other things are needed, yeah? Equipment and that sort of thing. What makes it excellent? What's the story? What's the consequence if it goes badly wrong? And what makes a good role? So we mentioned that, and with great training style. I mentioned that in the previous page, and overstretched myself so as not to have anything to talk about on this one. But we got to collect the data, all right, and that's the key bit. You bring it together. So then, how do you use that to model through different options for people? Well, the trick then is to say, right, of all those tasks that we're doing, are we doing those tasks? If we're doing those tasks, can we do them better? And can we change who does those tasks? And here's a few ways that we can look at things. First of all, we can put them in an analysis table, okay? And as we go through, we'll need to keep filling this in. So we've received and reviewed the referral, we've got a decision, non-urgent, nurse, handle admin, review referral, decision simple, it's a decision point, GP clinic, and refer to tertiary. So we've got the steps, including the decision points, yeah? We've got who does it at the moment, yeah? We've got the importance of it, yeah? We've got the competencies that are needed, and we've got the behaviours and attitudes that are needed, all right? Now, what we can then do is to think about then, right, what other roles could then do it? So a GP could do it because they've got attention to detail, they can organise and they can file. Yeah? A nurse could do it, an AHP could do it, okay? But in these particular cases, a nurse can't do this one for whatever reason, because they're already doing it. In this particular case, an administrator could do it. In any of these other cases, that other administrators can't do it. Interestingly enough, we've got one there where an administrator is doing it. So we'll, oh yes, because the administrator is doing it at the moment. So an administrator could do that one. So I need to add in administrator into that one there. Just trying to work out why my slides are wrong. But essentially, you put down what other roles could do it. And then we can go through a set of options as to who could do it. So let's look at those different options. So one thing we can do is put things in swim lanes as to who's doing it. Yeah. So we know at the moment that in this particular case, an administrator is doing this bit, nurse is doing this bit, and the GP is doing this bit. Okay. Great. Okay. So we know that's what's happening at the moment. So that's a great way of showing it because it allows us to move things around. Because we can then say, how do we change the roles? So what we could do is say, well, could the administrator do all of these bits, for example? Yeah. So could the administrator do that? And could the nurse just do this bit? Sorry, could be the administrator, could be the HP. But we'll say it's the administrator. Could the administrator do that? Could the nurse do this? Could the GPs do this, for example? Okay. So we can change the roles between things and move people into different roles. What we can do is we can simplify it and give it all to one person. All right. So we can say, can it all be done by one person? Now that is great because that makes things a lot easier if we can. All right. So we could say, could it all be done by one AHP? Or it could be done by even the most expensive member of staff, because by doing it, we cut all these other tasks out. So the reason we review the referral, going back to here, is so that we can work out if it's non-urgent or if it's urgent. And if it's non-urgent, it goes to a nurse clinic or whatever. We could say, could an AHP do it all? Yeah, a suitably trained AHP do everything. Yeah, could be a GP clinic, could be whatever. We've changed this for an AHP clinic, all right? So we've just decided somebody else could do that all, yeah? Okay. So there's a whole host of different things we can do. We can change the skill mix, so we can just move staff between roles, yeah? And that's the easiest way of doing it, okay? But what it often does is, it's often called working at top of role. So you move all the administration stuff to an administrator, you move all the complicated stuff to the most complicated staff member, and off you go. There are dangers to that, though. And we'll talk about that in terms of the different options around things. But the key thing is you don't want to make roles too stressful or too boring. So hyper specialized can be dull. It can also be stressful on people that are doing the stressful parts of that process. You can widen the job by expanding or enlarging the role, bringing together functions that were done by different individuals. All right. So what you can do is you can say, as we've said there, an AHP could do all of this stuff, and you're bringing together everything to expand it but simplify it at the same time. Okay, and that can be nice, but it can also introduce some stuff that they're not necessarily good at. AHPs might not be great at admin, and that can be a bit of a problem. So it's kind of different roles around that. You can deepen the role. Okay, so you can enrich the role by giving the role more significant and substantial responsibilities, greater autonomy or opportunity for development. So that is where, for example, in that particular case, you might be giving the administrator something that deepens their role, makes it more, in some cases, more expensive, but gives them a greater role in what they're doing. Or you can create an entirely new role. Now, creating entirely new roles is best left to the experts at NHSIE and Health Education England, because creating a new role, you do need to think about quite a lot that's associated with it, and creating lots of new roles can create lots of new silos. What I'd be saying to you is, can you simplify things? I don't like lots of moving to top of band. I hate that sort of stuff. Administrators just administrate, GPs just GP, hyper specialized roles for lots of people. I don't like that very much. I like elements of it. I prefer things from a GP point of view of combinations of that, by giving the GPs the leadership role plus some work in various different levels, but also giving others the chance to see patients, sometimes even administrators if you get them involved in social prescribing roles and stuff like that. I like to widen things out. I like to have one person seeing, doing everything with one person that they see, not lots of individual silos. So I like job widening and job deepening. I don't like new role creation done on the fly. There are some great new roles out there, don't get me wrong, but they are in STAR. They're in the. You can search for new roles. They've been done. Yeah, first contact physios, all that sort of stuff. Physicians associates, that sort of thing. These have all been done already. So have a look at those as part of your data review. Right. Okay. So I've banged on about that too much. Right. There are a number of different things to think about when it comes to redesigning your role, though, which goes beyond just which tasks that you move them in. So you need to think about remuneration, especially banding, if you're looking at this from an admin point of view. Are the changes going to make a difference to remuneration, and what impact is that going to have on your model? I much prefer there to be fewer well-paid people than lots of poorly paid people. That's just my preference. So I like banding going up as long as the value goes up. I don't like banding just going up for banding's sake. We need to understand the volumes that they are going to be doing. Is this going to have an impact on the volumes? And we need to put that in the model. But we do need to think about lots of other things. What's the supervision going to be required for these roles to make it worthwhile and to actually make sure that the outcomes work? Supervision is very important, and how much time is that going to take? I quite like GP-led or consultant-led rather than consultant-delivered, but they do need time to lead and supervise. How much training is going to be needed? What needs training immediately? What needs training later on? What's the job description going to look like? What is their responsibility for the process, from input to outcome? What's the career route? It's no good having a great role for a receptionist in a GP surgery if we don't know what they're going to move on to, because we'll just have really, really good GP receptionists until they need to earn more or get greater opportunities elsewhere and become a practice manager elsewhere, or jump to become and work in local authorities or something like that. So you need to have a career route for them. It might involve those other companies, but we want to have a career route for them. What else makes the role attractive? So you can bring that out whenever you're hiring and focus on that. What makes the role excellent? What is the union engagement we need to do? What communications do we need to do? And what are the financial implications of this, both in terms of what budgets do they have to manage, but also how do they fit within our overall budget. So you need to consider all of those things when you're doing role redesign. So that's it. Process and workforce redesign rattled through there as a separate section. I hope you found that useful. Plenty more of that on the internet if you want to have a look at it. But if you want to carry on your journey with us, then you might want to register to the RAP tool if you haven't done so. You might want to buy the bumper book of Health and Care Workforce Planning, available June 2021, end of June. On Amazon, you might want to visit the RAPT website, www.rapt.org.uk. You might want to visit Health Education England Workforce Planning pages, or the Carados website, where you can also get in touch with me through the information portal or email thing, whatever is on there. You might want to continue the stuff with us. You might want to continue the RAPT redesign course, the RAPT plan course, and hub and frontline courses, all very short. If you want to learn about workforce plan development, workforce hub creation, and the skills you need for frontline workforce planning. Please, if you've enjoyed this, like it, subscribe, ring some sort of bell, and comment, I believe, is the other thing that should be doing, but subscriptions are helpful to get this up the search algorithms. Excellent. Okay, so that is that for this little course. I'll be recording another one on facilitating a workshop later on this week. Cheers.